So guys, we're talking about pulmonology. This is the physiology of the respiratory system. The lecture today is about the dead spaces and the ventilation rate. I believe in the respiration, there are 3 or 4 questions over here and even the mathematical questions that might be there in USMLE. So pay attention, important topic, an interesting topic as well. So let's start. First of all, anatomical and physiological dead space. Look, when we inspire, when we inhale, the gases in the air, they pass through either our nostrils or our mouth from this area, from the pharyngeal area, and then from there to the trachea, and then bronchi, then all the way down to the bronchioles. And normally what happens is this area, the nose and the pharynx and the trachea and the bronchi, this is normally just the conducting area. And why is that important for us to know? Conducting zone or conducting area? Because there is no gaseous exchange that occurs here. Why is that important for us to know? Because when we'll be doing calculations, it is important to understand where is the gaseous exchange not happening and then use that in our calculation. Also, we'll see that in areas where the gaseous exchange should occur, sometimes those areas also are not functioning properly, and we have to calculate the problem in that area as well. We'll do that all together today. So conducting area are the areas where the gas exchange is not happening, just conduction of the gases is happening. Then we reach a point where we have something called respiratory zone. Respiratory zone. And what is that? This is the area where gaseous exchange can actually happen. What does that mean? This is the area which has terminal bronchiole, not bronchi. Terminal bronchiole are thin enough that they can allow the oxygen and carbon dioxide exchange to occur. Then alveolar ducts, so these are alveolar ducts. Terminal bronchioles, alveolar ducts, alveolar sacs, so this area is called alveolar sac, and then individual alveoli, alveolus. This all is called the respiratory zone. Why is it called the respiratory zone? Because gaseous exchange can happen here. So that means the whole airway can be divided into 2 proper anatomical segments. One segment that just conducts the air and it does not participate in gaseous exchange, and the other segment where the gaseous exchange actually happens. The anatomical area where gaseous exchange does not happen is called anatomical dead space. And what does a dead space mean? Dead space means that air is present to have the exchange happen, blood is present there as well. This is anatomical. I'm not talking physiological. I'm not talking pathological conditions. Anatomical. Blood is present as well, but the wall between the blood and the gases is so thick. So if there is a blood vessel here, the wall between the gases that are here and the RBCs that are sitting here, this wall is so thick that gaseous exchange is not possible. So all such areas collectively are called anatomical dead space. It is the part of the airway that does not take part in the gaseous exchange. Now, how do you assess the anatomical dead space? Normally, a person's weight in pounds is almost equal to the dead space. For example, my weight is about 155 pounds. That means I have about 155 milliliters, not liters, milliliters of the dead space. So normally in the books we say that for a young man, normally 150 milliliters is taken as the anatomical dead space. Okay, so this is the respiratory zone now. Respiratory zone sometimes also malfunctions. It also becomes pathologically bad. So what can happen is, for example, imagine if in the alveolus there is some sort of mucus plugs or edema or infective exudates sitting here, and now even when the blood is present here and the gas is present here, the exchange is not happening because there is an abnormal secretion here which is causing the respiratory membrane to become thick, and the respiratory membrane and the gas exchange and the gas equation is a different lecture. This is not that lecture. Just understand the structure at this time. So if this becomes thick, then a normal respiratory zone that is supposed to be functioning as a respiratory area will become non-functional. So now as a doctor, what we want to understand is, in a patient, in a person, is there any area in the normal physiological breathing part that may not be working? And imagine if we find out that, okay, in Mobeen's lungs, over here there is 10% of the area that is not functioning correctly. It is not doing gaseous exchange because of some pathology. Then you take the anatomical dead space, plus you add this extra alveolar dead space, you combine them together, and that is called physiological dead space. Or simply put, the total dead space in the lungs, regardless of their zone, is called physiological dead space. The total area that will not take part in the gaseous exchange is physiological dead space. Physiological dead space mathematically is equal to anatomical dead space plus alveolar dead space. Now let's very quickly look at this as well. So what we'll do is this. Let's say this is an alveolus. This is an alveolus, and we have made it bigger and we are looking at it. So alveolus has, of course, its own little pneumocytes and type 1 pneumocyte and type 2 pneumocytes and macrophages and blah. So this is that structure. We've done that in histology of the lungs. This is the area where there is alveolar membrane, then there is interstitial tissue, then there are blood vessels, and of course capillaries, and these capillaries have endothelial cells, correct? So this together, all of these things together are making respiratory membrane. Respiratory membrane. This is the area of gas exchange. Carbon dioxide comes out, oxygen goes in. And just keep this in mind that on the arterial side, when the gases, heart pumps the blood to the lungs, and in the lungs the gaseous exchange happens, then the blood comes back to the heart, to the left heart, to be sent to the body. That gas composition in there, the partial pressure of oxygen in arterial gases, arterial is small, is about 100 millimeter of mercury, and partial pressure of carbon dioxide on the arterial side is normally about 40 millimeters of mercury. When the same blood passes through the tissues and tissues extract oxygen out and contribute carbon dioxide back, then when this blood reaches the alveolus over here, when it is entering the lungs, right? So blood comes back to the right ventricle, right atria and ventricle, right heart. From there the right heart pumps it into the lungs. When it comes into the lung, partial pressure venous oxygen is about 40, so it has dropped from 100, and partial pressure of venous carbon dioxide is about 46 millimeters of mercury. So these are the compositions in the arterial and venous bloods when they reach when they are circulating through the lungs. Now the question is, after doing the dead spaces, We've done the dead spaces. What we've talked about is anatomical dead space, alveolar dead space, that dead space that alveoli are not functioning. What kind of non-functioning can happen? There are multiple ways that an alveolus can not function. One is that you're seeing here, that alveolus is plugged and there is blood present here and saying, okay, give me the oxygen and take the carbon dioxide, but alveolar membrane has become so thickened that the exchange is not happening. Or the alveolus is fine, it is healthy. Let's say we take this alveolus, but the blood vessel that brings the blood to this area somehow is plugged. Somehow the blood vessel is broken, somehow it is unhealthy, maybe there is an embolism, maybe there is a thrombus sitting in there. The result is there is no blood circulating. So now oxygen is sitting there saying, I can jump into the blood right now, but there is no blood there. That is also malfunction. Then what could happen is that this respiratory membrane, the interstitial area, the area between the alveolus and the blood vessel, interstitial part, that can become fibrosed. That can become scarred, that can become, interstitial diseases are possible. So if that becomes thick and scarred and fibrosed, then the exchange will not happen. So even the physiologically active area can become inactive. What we now need to understand is, so total dead space is physiological dead space. Now what we need to understand is, how does this gaseous exchange with the inspiration and expiration, what happens to the alveoli and what happens to the composition? That data that we will see here will then use in the ventilation rates. The second thing of doing this, the composition, is that we want to calculate the physiological dead space. So let me first show you the formula of calculating it and then make sense of that formula. Students try to just memorize it and try to just say, okay, I'll just write it down. It is actually easy to understand. Look, here is the basic formula. The formula is the dead space, I'm going to write it here, dead space, volume of dead space equals volume tidal. So that is the volume that we are at rest, in quiet breathing, we are taking in and taking out. In a normal young man, it is about 500 milliliters of the tidal volume multiplied with, and what we have to see is, we have to say physiological dead space. Fraction of the physiological dead space. That is the basic formula. Now how do we calculate this fraction? Fraction means what percentage of the whole lung volume is not participating in the exchange of gases. We take that percent, let's say 10% is not working. That means the tidal volume, if 500 is a tidal volume and 10% is a dead space, then that means about 50 milliliter is the dead space over there. So that is what we have to calculate here. How do we calculate that? We do that by this. So I'm going to expand this. I'm going to say pressure, oxygen, PaCO2 minus the P expired or expelled CO2 divided by PaCO2. What does that mean? What it says is this. Look at the alveolar carbon dioxide composition, which is going to be equal to actually the blood carbon dioxide composition, and I'll explain why. Why not I just explain it right now? Carbon dioxide through a healthy lung, when it passes, the respiratory membrane allows a very rapid carbon dioxide equilibrium. So carbon dioxide, if it is present here and the pressure is 40 millimeter, then the pressure is going to become 40 millimeter in the gas inside the alveolus very quickly as well. If the pressure here is 50, then the pressure of PCO2 here will become 50 as well. So normally the pressure of carbon dioxide in the blood is assumed to be the same as the pressure of carbon dioxide inside the alveolus, and vice versa. If you are curious at, hey, what is the alveolar carbon dioxide pressure, you can look at the venous pressure or the vice versa. So here we take the carbon dioxide pressure, we subtract the pressure in the expelled air. That is, you put some meter here, you take the carbon dioxide, or you collect the gases coming out with the expiration, and you see the percentage of carbon or pressure of the carbon dioxide in that. You subtract them and divide that with the total carbon dioxide pressure, and that gives you the fraction. What is this fraction? This is the inactive part of the lung fraction. You multiplied this fraction, 5%, 2%, 1%, 0%, multiply that with the tidal volume, and that would give you the physiological dead space. So for understanding this, we have to understand the alveolar compositions. Once we understand the alveolar compositions, then we can derive this. So let's do this. Imagine that you are exhaling. When you are exhaling, first thing that we should know is what is the total residual gas volume in the lung. So what is the functional residual capacity? It is equal to residual volume, which is about 1200 milliliters, plus expiratory reserved volume, ERV, and that is about 1200 milliliters. So let's do that. We have residual volume is about 1200 milliliters. This is the gas that is always present in the lungs. Plus we have expiratory reserve volume, which is about 1200 as well. So let's say 1200 milliliter. So total volume in the lung is 2400 milliliters. On top of that, make an inspiration, tidal volume. Tidal volume is normally 500 milliliter, right? So a normal healthy young man doing tidal quiet expiration and inspiration, 500 milliliters. Women are about 15 to 20% lesser. So add plus 500 to this of tidal volume, and you have about 2900 milliliter of total volume in the alveolar system. Now what we are curious is, please pay attention here, what we are curious is, out of this 3000, about 3000 milliliter, did all of it take part in the gaseous exchange, or some part went to a non-functional part of the lung, did not do any gaseous exchange and just came out? So let's see this. First, here the composition, what is the composition? We talked about that here. Inside the alveolus, the blood has brought carbon dioxide here. So the pressure of carbon dioxide is about, let's make an assumption, let's say the carbon dioxide pressure is 40 millimeter of mercury. Oxygen is taken up by the blood. So let's say that the oxygen's pressure here is 100. After taking up, oxygen pressure left here is 100 millimeter of mercury. Now that is the situation. So I took a breath, and now the exchange is happening. At the end of that exchange, before I exhaled, this is the composition of the gases. Now I exhaled. How much did I push out? 500 ml. In that 500 ml, there was a part of gas that was pushed out from this part, this neck of the balloon here. This neck of the balloon represents the anatomical dead space. What is the composition of the gases here? Is it the same as that? No. But what is it? We'll answer that when we'll reach here. So just imagine this for the time being. As the gases start moving out from here, the volume of this is 150 milliliters. What does that mean? That means this whole pathway, the black pathway, can contain 150 milliliters of air in it. Now when the air started moving out, 500 ml is trying to go out. 350 ml came out. 350 ml air came out. 150 ml got stuck in the airways. Why is it not going out? Because there is no further pressure to move it out. So we think that the 500 came out, But in that 500, initial 550 was coming out, which was already present here. So hold on with me for a second. 500 milliliter is pushed out. When it came out, we had, here is a chunk of air. I'm going to make that here. The 500 ml that came out, that is the structure. What came out is 150 that was already here, 350 from the alveoli, and 150 from the alveoli got stuck here. So basically, this is 500 ml, right? This is the alveolar gas that got pushed out, and 150 is stuck here. What is the composition of this? This is the same composition as the alveolar, which is carbon dioxide 40 and oxygen 100. How about this 350 that went out? Same as the alveolar composition, which is carbon dioxide 40 and oxygen 100. How about this? We still do not know it. I'm going to put a question mark here. We still do not know it. Okay, let's continue. Now, this air that has come out, 500 ml, this air got dissipated, dissolved in the room air and just went away. So now you got fresh air in the room that is around your mouth. You take another inhalation, you inhale some air. How much? Tidal volume 500 ml. So inhale that right now. 500 ml went in. Now that 500 ml, look at this, how would that happen? So let's make that here. So what do you think is going to go back into the alveolar system first of all? This 150 that was stuck in the anatomical dead space, was it doing any gaseous exchange? No, it is anatomical dead space. What was the composition of this? This had the same composition as the previous alveolar composition, which is carbon dioxide 40, oxygen 100. That thing is going to go back in. Okay, so we got first 150 milliliter, that is just the dead space air that came back in. So this was the dead space air. This air just came back. Did it do anything in the anatomical space? No, it was just sitting there. Okay. Is it useful for the exchange? No, it has the same composition as the venous blood. It's not going to do any further beneficial things here. Okay, so then should we get more air? This is not very useful for respiration. Yes, we should get more air. What is that more air? Out of the fresh air around, 500, a chunk of 500 ml fresh air, new air is going to go in. First 350 ml are going to go in the alveoli. What is their composition? Their composition is about 150 oxygen millimeter of mercury and carbon dioxide about 0. Why we assume it's about 0.2, but let's say 0. So pressure of carbon dioxide is 0, pressure of oxygen is 150 millimeter of mercury. That is this gas. Is this gas useful for exchange? Yes. Why? Because it has more oxygen, less carbon dioxide, so it would create that gradient and we'll have exchange done. Cool. So we got 350 ml in the whole lungs. That is new air. What happened to an extra 150 here, which was also new, fresh, good air? Well, that got stuck here. Where? In this anatomical space. 150 ml got stuck here. Is it useful air? Yes, it is good air. Can we use it? No, because anatomical dead space doesn't use the exchange, doesn't do the exchange. So, did alveolar system, respiratory zone get 500 ml? Yes. What was that 500 ml? 150 stale, 350 new. Okay. Now we know what is here. This is the same as this, because after this we'll exhale again. Inhalation, exhalation, right? So now we are going to do gaseous exchange. We'll go down to once again the composition that we talked about here, and then we would expel this again. So when we'll expel this air, we'll go back here. What do you think is going to happen? What is going to happen? When this air comes out, now do you know what is this composition? This air's composition is the same as this, that is oxygen, 150 millimeter of mercury, and carbon dioxide, about 47 millimeter of mercury. Oh, sorry, 0. This is the room air. With 47 millimeter of water vapor and about 540 nitrogen, right, at 37 degrees temperature. Now let's calculate minute ventilation rate. Minute ventilation means you are standing outside, a person is ventilating for 1 minute, breathing for a minute. How much volume? Guys, it's very simple. One breath, if it is 500 milliliter, and let's say if in 1 minute I took 10 breaths, then what do you think, how much gas did I take in or I exhaled? One of these, either in or out, you measure one. 500 multiplied with 10. So let's do that. Minute, I'm going to put that here. Minute ventilation rate, ventilation, I hope I knew spellings. Ventilation rate equals, what is this? You take the tidal volume, multiply it with frequency of the breathing. Let's say breathing rate is 10. So in this person it is 500 milliliters per breath, and 10 breaths equals 5000 milliliters per minute. Don't forget to say per minute. That is 5 liter of the air is exchanged. Okay, just like 5 liters of cardiac output, similarly 5 liters of the air. How about alveolar ventilation? Alveolar ventilation. What are we talking about? We are saying out of this 500, how much did the alveoli got? Ideally they should get 350. So what you should do is this. You should say 350, so that is tidal volume minus dead space, anatomical dead space, multiplied by breathing rate 10. So what is the total? 500 tidal volume. What was the anatomical dead space in our example? 150. 350 multiplied by 10 is 3500 milliliter per minute. So the actual gas that became available for exchange is 3.5 liters. So this 5 liter has only from outside the gas, but the actual gas available to alveoli is 3.5 liter. Now this assumes that alveoli are all functioning, blood is fine, interstitial spaces are good, respiratory membrane is good, blood supplies are okay, so all physiologically normal processes. If for some reason alveoli are not working correctly, now we are here, alveoli are not working correctly, how would you know that? Guys, it is really simple. What you do is you take the fraction of alveoli that is not working. Here is a confusing part where students get stuck, and let me clear that, rest is fine. They get stuck at the carbon dioxide composition in the alveolus and the carbon dioxide composition in the air. Which one should be more? Think about it. Blood comes to the lungs, the carbon dioxide level is 46. That carbon dioxide level gets exchanged with the alveolar gas. So let's say alveolar gas is 46. Now when that gas comes out, should the carbon dioxide exhaled have the pressure of 46 millimeter of mercury, or 48, or 40, or 30? It should be lesser than 46. Why? Because when this gas comes out, it is going to mix with the dead space gas, that anatomical gas here, which is doing nothing, that is sitting at 0. So now we're getting some gas that has a concentration of 46 millimeter of mercury carbon dioxide, and then there is gas sitting here that has 0 millimeter of carbon dioxide of mercury pressure. When they both mix, the pressure of carbon dioxide is going to fall. So that means expired carbon dioxide pressure will be less. Okay, if that is the less, then what we can do is we can say how less, and that would tell us how much dead space is present. That is exactly the point here. So how less will show us in this way. Let's say here is the anatomical dead space. This is the trachea and the bronchi and the bronchioles and all that. And then there are two alveoli, alveolar or respiratory zones instead of one. I've been using one here. There are two respiratory zones. One of them is not working. One of them is working. This is doing gaseous exchange. This one is not doing gaseous exchange. Now the gas that went in, guys pay attention to this one. Gas that went in here did not participate in the gaseous exchange. So the carbon dioxide level here is 0. Gas that went in did the gaseous exchange and the carbon dioxide level became, let's say, 46, which was also in the blood. When this 46 came out and mixed with the anatomical dead space, let's say the pressure dropped to 43. But this abnormal part, which should not have been bad, it should have been working, also provided gas back with the 0 carbon dioxide level. This is the confusing part, student forget. This sent the gas back with the 0 level. The dead space has extended into this physiological unit. When that got mixed as well, then this would drop even further. It would go down to, let's say, 39. So what you do is you calculate here. So let's say that we have a patient here and we are calculating his tidal volume is 500, which is this, and let's say his carbon dioxide pressure in the blood or alveolar is 40, but carbon dioxide pressure that you measure in the expelled air is 36. Then you do this 40 minus 36 over 40, which means 500 multiplied by 4 over 40, which is, right, so you can now see this is going to be 1/10, so 50 milliliter. This is the physiological dead space. This is the physiological dead space. This is for one breath, just like stroke volume and cardiac output. Stroke volume is for one cardiac beat. This is for one breath. Now if you wanted to convert that into the alveolar ventilation, then over here when we said take the tidal volume and subtract the dead space, what are you going to subtract? You're going to subtract this. So you take 500, subtract 50, and then multiply it with the breathing rate. So what would be the answer here? You'll take 500 minus 50 equals 450, multiply it with 10 equals 4500 milliliter per minute. That is the alveolar ventilation. What was the minute ventilation? 5000 milliliter. So that is how you calculate that. Hope this is clear. Let's quickly do a couple of things over here, a couple of questions here to understand to apply this knowledge. Let's have a problem here. A patient comes to you or a person comes to you, don't know if he's a patient yet or not. Breathing rate is 10, vital capacity, tidal volume is 500, oxygen pressure in the alveoli is 40, expelled air, oxygen, I should make it carbon dioxide. Somehow today I've been confusing carbon dioxide and oxygen. Carbon dioxide is 36. What is the dead space volume? What is the minute volume or minute ventilation, and what is the alveolar ventilation? So we did the dead space over here. How will we calculate the dead space? We'll calculate the dead space with this one. So we'll do this. We'll take tidal volume 500, multiply it with, what is the 40 minus 36, 40, this is the one we just calculated there. So this is going to come out to be 50 ml per per breath, not per minute. Okay, so that is a dead space, physiological dead space. It includes anatomical dead space, total dead space. How about the minute ventilation? So multiply this number minus this, that is the total, take the tidal volume, multiply it with the frequency, which is 10, that would give us 500, multiplied by 10 is 5000 milliliters. So 5 liter per minute, now per minute, because we have multiplied with the breathing rate. 5 liter per minute is the breathing rate or the minute ventilation, not breathing rate, minute ventilation. How about alveolar ventilation? Alveolar ventilation is going to be tidal volume minus the dead space multiplied with the breathing rate. So 500 minus 50 and that. So 500 minus 50 multiplied with 10 is going to be 4500 milliliter per minute or 4.5 liter per minute. Cool. So that is the example of a patient or a person with a breathing rate of 10, tidal volume of 500, PaCO2 is 440 and PeCO2 is 36. Okay, now let's see 3 patients that have this data in front of you. Patient A or person A, we don't know if he's a patient or not, is respiring with the frequency of 10 breaths per minute. His tidal volume is 500. What do you think his minute volume is going to be? 510, 5000, so 5 liter, right? 5000 milliliter divided by 1000, 5 liter. So that is his minute volume, minute ventilation. How about his alveolar ventilation? Alveolar ventilation is going to be, we are going to assume 350, 150 is the dead space, so 3500, so 3.5 liters. Good? We are going to assume 150 for all of them. Patient B or person B has a ventilation rate of 10. His tidal volume is 600. So what do you think is his total? So 10 multiplied by 600 is 6000 milliliter, which makes 6 liter. So this person has minute ventilation greater than person A. Because is his frequency of breathing more? No. Is his depth of breathing more? Yes, he is doing or maybe the person is large. So 10, 600, 6 liter. How about his alveolar ventilation? What is the actual gas going to the alveoli to take part in the gaseous exchange? If 150 ml is anatomical space, dead space, then 600 minus 150 leaves you 450. Multiply it with 10, you'll have 4500 or 4.5 liters. Cool. So this guy clearly has a higher minute ventilation plus a higher alveolar ventilation. Okay, let's check out this person. This person C has a frequency of breathing which is 22, very high breathing. Okay, how about his tidal volume? His 300 ml, which is high volume, high frequency, shallow breathing. 300 ml, let's see how much liters. So this would become 66, 3 multiplied by 2 is 6, 3 multiplied by 6600 milliliter, 6.6 liters. So here is your test, This person has 6.6 liter of minute ventilation. So you are standing out there in front of B and A and you have a meter and you're measuring their ventilation. One is 6 and one is 6.6. Who do you like more? Who is taking more oxygen? Who is more powerful right now? Who is more oxygenated? Ideally this guy. But remember, minute ventilation doesn't tell alveolar ventilation. We have to yet account for the dead space. So what do? You take the dead space. What was the dead space? 150. Remove that dead space from the tidal volume. What is the tidal volume? 300 minus 150. What is left? 150. Multiply that with this. It's a half, right? So if this was 6.6 liter, then half of that is going to be 3.3 liters, 3300. Now tell me, these two guys, this guy, C guy, has ventilation, minute ventilation higher than the person B, but alveolar ventilation is way lower than the person B. This guy is actually not breathing correctly. This guy has a problem. So what is the important thing here, and what would USMLE want you to, why do they want you to know this? Just by frequency of breathing, you should not try to figure out that the patient is okay or person is okay. It has to be alveolar ventilation that would actually tell you what is the situation of oxygenation and gaseous exchange. Thank you.